Good afternoon. I'm Dr. Bruce Vanderhoff, Director of the Ohio Department of Health. Sadly, we continue to see an uptick in COVID-19 cases and hospitalizations. Yesterday, more than 8,900 positive COVID-19 cases were reported in the previous 24 hours, with 425 hospitalizations. These numbers are comparable to what we were experiencing at the peak of our fall surge. Indeed, the last time we saw 24-hour case numbers this high was on September 10th, when we saw more than 9,000 cases reported. Similarly, at the peak of our fall surge, we saw a total of more than 3,700 patients hospitalized with COVID-19 across the state, reaching that high figure on September 27th. Yesterday, we reported more than 3,800 inpatient COVID hospitalizations, higher than at its peak during our fall surge. In fact, the last time more Ohioans were being treated in the hospital for COVID-19 was all the way back on January 12th, when 4,000 patients were hospitalized across the state. Now, much as we discussed last week, these cases aren't necessarily occurring evenly across the state at any point in time. We're seeing fluctuations in cases in different regions and different counties. Currently, we're seeing the highest incidence of new COVID-19 cases in the northern portion of the state, with the highest concentration of hospitalizations in the northeast corner of Ohio. When we look at trends across ages, what we see is that younger Ohioans, specifically those between the ages of 23 and 49, have a case rate per 100,000 that's 25% higher than the statewide average. And of course, when we look at those who are hospitalized with COVID-19, they continue to be largely the unvaccinated. The COVID-19 vaccines, as we know, are designed to protect us from severe cases resulting in hospitalization or death. So while someone who's fully vaccinated may in some instances still catch COVID-19, they are far more likely to be able to weather that case at home rather than ending up in a hospital or on a ventilator or in the obituary pages. Although we are, of course, very concerned about the high number of hospitalizations, particularly in Northeast Ohio, our strategic hospital zone system allows our hospitals to work together to address patient needs, discuss approaches to shared challenges, and shift some care within and between regions. Joining me today to discuss what hospitals in Ohio and across the country are facing is Dr. Andy Thomas, the Ohio State University Wexner Medical Center Chief Clinical Officer and Zone 2 Hospital Lead. Dr. Thomas, in Ohio, as well as other states across the country, hospitals are seeing very high numbers of patients. I've just reviewed some of those numbers, both those with COVID and those who have other medical conditions and other needs. Can you refresh our memory on how Ohio's zone structure works and has allowed hospitals to help one another?
I'd be happy to, Bruce. Thanks for having me here today. So the three zones were set up back in March of 2020, and it took Ohio's 8 emergency management regions that were really set up for things like tornadoes and floods. And we realized that the way patients flowed within our state didn't really make for 8 regions, but 3 made more sense. So the Zone 1 stretches all the way from Toledo across through the Cleveland, Canton-Akron area over to Youngstown in the northeast part of the state. Bob Wiley, who's Chief Clinical Officer or Chief of Clinical Operations at Cleveland Clinic, is the lead in Zone 1. I'm the lead in Zone 2, and we stretch from Columbus and the contiguous counties around Franklin County all the way northwest up to near Bell Fountain, and then essentially everything down 23, down 33, and out 70, that southeast quadrant of the state. And then Rick Lofgren, who's the CEO at UC Health, leads Zone 3, which are the Dayton and Cincinnati metro areas, and then all of the counties that surround Dayton and Cincinnati in the southwest quadrant of the state. I can speak best about obviously what happens in my own zone. I can tell you that we on a daily basis during the week at 9 a.m. of over 40 hospitals and health systems across Zone 2 on a call where we literally walk through hospital capacity, COVID census, and the ability of hospitals to accept transfers from other hospitals across the zone each day. We can get through, because we've been working together now for 20 months, we can actually get through that work usually in about 15 to 20 minutes and share a lot of information quickly. We've had to move PPE, we've had to move ventilators, we've had to move other medical equipment around between hospitals in the zone. Then also what we call lateral transfers is where we move patients from one community hospital to another, where traditionally they might have come to one of the Columbus health systems. We've been able to build partnerships between community hospitals where they are working together to make sure that the right patient is cared for at the right time with the right resources in the region. We've had hospitals that have had everything from computer system issues to other weather-related issues, needed to shift patients. It's been just a really rewarding partnership, and I think something that if you look across most of the states in the country, they've not built this sort of a system with collaboration between the state, between your office, between the governor's office, the Ohio Hospital Association, and then the individual hospital zone leads across the state. It's been very rewarding and I think very helpful in making sure that we've been able to weather this pandemic as well as we have.
Thank you, Dr. Thomas. You know, as many people listen to these very, very high numbers, not only cases, but hospitalizations, I'm sure many are thinking back to the early days of the COVID-19 pandemic when we shared that our hospitals were making plans for expanding the number of beds they had available by building auxiliary facilities, tent hospitals, and other surge plans. However, the problem right now isn't really necessarily physical capacity or physical beds, but staff. Can you share with us a little bit about the challenges that Ohio's hospitals are facing and how Ohioans can really help to lighten the load that is being borne right now by our hospitals and health systems?
I sure can. So a couple of things related to capacity issues. One, I think you're exactly correct, Bruce, that staffing is a major limitation at most of the hospitals in my zone, and I would say most of the hospitals across the state. We've seen news reports of hospitals that have needed to close beds. And I would say almost every hospital really doesn't have that same elasticity that maybe we had this time last year to really be able to expand capacity on a short-term notice when there's a flood or a surge of patients in your local region. The fact that hospitals have beds closed means that you're really capacity constrained, not just for COVID patients, but for patients that have a heart attack or patients that have a trauma that maybe in the past would have been taken care of at their local hospital. But now those patients are going to need to be moved to a different community just because that hospital already has 10 or 15 admitted patients in their emergency department. I think in the northeast part of the state, as you highlighted, those concerns are of even a greater degree than they are right now in the central part of the state or in the southwestern part of the state. We actually had a call yesterday between some Zone 1 and Zone 2 hospitals looking at sharing patients between zones just because they're really in a difficult spot in the northeast part of the state. And to your point about what people can do to help, it's really about vaccination. To your point earlier, Bruce, I think that certainly individuals that are fully vaccinated or in some cases even fully vaccinated with the booster may get a breakthrough case. I think there's also ample evidence that the risk of getting an infection if you've had a significant exposure is far less if you're vaccinated. But what's really important, at least in what we've been talking about, is the opportunity for you to get vaccinated means you don't have or you're at lower risk, I should say, of developing pneumonia, of developing low oxygen, of needing to be in the hospital, in the ICU on a ventilator, or God forbid, passing away. And that's really the game changer that will help Ohio's hospitals. In your hospital, in your local community, when you go in with a gallbladder attack or when you go in with a cellulitis on your leg and they're saying they can't take care of you and you're being shipped an hour away, it's partly all of these things. Patients are sicker. Our length of stays are longer because a lot of those patients that maybe sought to put off care during the pandemic are showing up sicker with non-COVID issues than they did before. But really the ability of folks to get vaccinated will reduce that number of cases, will reduce that number of hospitalizations and allow us to make sure that we're maintaining the flow of patients and the quality and safety of our care moving forward across the state.
Thank you very much, Dr. Thomas, for that very good explanation. At this time, while we face very high cases and hospitalization statewide, Delta remains the dominant COVID-19 variant in Ohio. As you'll likely recall, we detect variants by way of genomic sequencing, which is a process we've been engaged in now for many months. Genomic sequencing is performed on a positive PCR test sample when enough of the original sample remains and there's a high enough viral load in that sample to then go on and do further genomic sequencing. On the other hand, most of our rapid home-based antigen tests can't be sequenced. So on any given day, only a subset of all the positive tests out there are able to be sequenced. And the process of sequencing itself can take a few weeks. In many cases, the genetic code is associated with a particular variant that has been given a Greek letter, Greek name like alpha or delta. In some cases, it may be associated with a variant that hasn't yet been labeled, a variant of concern or variant of interest by the CDC. In either case, the identified variant is cataloged. And if that variant later is labeled as a variant of interest or a variant of concern with a Greek letter, it will show up on our dashboard with the Greek letter name. If not, it's labeled under the gray other section. So in short, genomic sequencing is conducted on as many PCR samples as possible, both by the ODH lab and the other labs across our state, which report the results right back to ODH. Now, because we're sampling as many PCR tests as possible, if the Omicron variant shows up in Ohio, we'll likely see it reasonably quickly in our state's genetic sequencing data. Now, speaking of the new Omicron variant, much remains unknown at this point, including whether it's more transmissible or capable of causing more serious illness. Early reports have suggested a tendency of the variant, the Omicron variant, to produce mostly mild illness, but that's based on very limited reports. Also, early indicators are that infection with Omicron could result in a positive PCR or antigen test despite its many mutations. So if you become sick with COVID-19, you should continue to seek testing, even if we start seeing this new variant here in Ohio. And remember, our diagnostic tests are designed to tell you whether you have COVID, not which variant you have. The importance of a positive COVID test is the knowledge that you need to isolate yourself and treat your illness, not the particulars of which variant is responsible for causing it. We do that more at a population or epidemiologic level. Now, of course, we expect to learn a lot more about Omicron over the coming weeks. But what we know now is that it has more than 30 mutations on the spike protein alone, so a lot of mutations. And these distinctive mutations actually allow us to identify the variant when a lab sample is then genomically sequenced. The variant, as you know, has now been identified in California. If and when it arrives in Ohio, rest assured, we'll be looking for it. So we don't know yet if Omicron will be more contagious, cause more severe or less severe illness, or be more deadly. But let's remember that there were other variants of concern, ones like Beta and Mu, which spread rapidly in other parts of the world, but actually never took hold here. Now with Omicron, as in the past with new variants, it is time that will tell the story, and we will be watching very closely. Importantly, at this time, we have no indication that our vaccines will fail to provide substantial protection against even Omicron. Especially, we're reassured that it does appear to, our vaccines do appear to protect against severe disease. In fact, Dr. Angelique Coetzee, who chairs the South African Medical Association, has shared that South Africa's hospitals were not overwhelmed by patients infected with the new variant, and that most of those hospitalized with Omicron, in fact, were the people who weren't fully immunized. This means that as we anticipate the potential emergence of Omicron right here in Ohio, there's a very important step that you can take to protect yourself and your community, and that's to get vaccinated. Don't delay your COVID-19 vaccine. If you haven't yet chosen to be vaccinated, go get your first booster today, your first dose today. Obviously, if you're eligible for a booster, get that today. With cases and hospitalizations on the rise from the Delta variant, and with a new variant right on the horizon, now is the time to protect yourself. Now, speaking of rising cases, especially amidst the cold and flu season that we're also now in, it can really be difficult to know whether you have COVID-19 or something else if you've got upper respiratory tract symptoms. So if you're showing symptoms of COVID, these are symptoms like cough, sore throat, fever or chills, headache, congestion, difficulty breathing, other upper respiratory symptoms, or if you've been exposed to somebody with COVID-19, you really should get tested. COVID-19 tests are readily available throughout the state of Ohio. Many pharmacies provide free drive-through testing by appointment, which you can often make the same day. Testing may also be available at your doctor's office or an urgent care or community health centers. And of course, free rapid testing kits are available at libraries, local health departments, and community health centers across our state. Although the rapid testing supply market is, in fact, still very limited nationally, thanks to strategic purchasing and distribution, Ohio has been able to maintain adequate supplies of rapid at-home testing kits. At this time, we have sufficient supply of COVID-19 test kits and are replenishing them as quickly as possible upon request. To date, the Ohio Department of Health has in fact distributed nearly 3.8 million free rapid testing kits. So if you become sick or are exposed, know that there are many options for testing available. If you test positive on a rapid antigen test, so one of those home tests, and you also have risk factors for exposure to the Omicron variant, such as recent travel, I'd really ask you to consider getting a follow-up PCR test, which can then be genomically sequenced and help us determine whether or not you might have one of the early cases of Omicron. And remember, if you test positive for COVID-19 and begin to experience severe symptoms, there may be treatment options available for you. Contact your healthcare provider or seek medical attention promptly. Now, today I am joined by Dr. Stephen Gordon, the chair of the Department of Infectious Diseases at the Cleveland Clinic. As we've discussed, we're seeing very high hospitalizations across the state, Dr. Gordon. Monoclonal antibodies, of course, have been proven to be very effective treatments for many of those at high risk for complications from severe COVID-19. Could you share with us, what are monoclonal antibodies? How do they work? And when and for whom are they most beneficial?
Well, thank you, Dr. Vanderhoff. And I want to emphasize, although we're going to be talking about treatment, our best prevention right now remains vaccination. So when we talk about neutralizing antibody therapy, it's been around for quite some time. And these are neutralizing antibodies that are actually derived from the convalescent plasma of recovered patients. And there's at least 100 or so neutralizing antibodies that have been FDA approved from diseases ranging from cancer to HIV. Now, when we're focused on SARS-CoV-2, it's important to recognize that we have 3 products that are authorized for emergency use, but not FDA approved. And the indications, as Dr. Vanderhoff mentioned, are for early mild disease, meaning patients who are not hypoxic, that is, have no big oxygen requirements, and early on in the disease. And this is for adults and even pediatric patients that are above about 82 pounds. I want to emphasize, though, that it's still a lot of barriers because it requires a positive test. It requires an intravenous infusion that has to be observed because there is the possibility of anaphylaxis. It's a one dose infusion. And as I said, it's going to work early if it's going to be effective, meaning before our own bodies have developed antibodies. So there's a time sensitive window in there. Where we found a lot of confusion is patients who are already admitted or sick with pneumonias, patients or their families are asking for the monoclonal antibody. And early studies show that it is not effective in that arena. And in fact, we have other treatments that we go to. The other space where monoclonal antibody is used is before the onset of infection, but maybe exposure, especially to the high-risk patients who have not been vaccinated. And in our experience, that has been a little bit put on the back burner because of the increase in cases in the focus on trying to get patients, as Dr. Vanderhoff has said, who are at high risk with early testing positive for COVID-19.
Dr. Gordon, of course, we've all heard that the FDA is evaluating oral therapeutics from two manufacturers at this time that are designed to treat COVID-19. But we've also heard that when they become available, they'll likely be initially in very tight supply. So although these aren't yet available, how could COVID-19 pill treatments act to supplement the existing monoclonal antibody therapies and help treat patients who are suffering from COVID-19?
Another great question and another great opportunity. So this, our focus initially was on vaccine. Therapeutics kind of took a back seat. And in fact, if you look at FDA approval drugs for COVID-19, we only have one, remdesivir for inpatient. So the outpatient space is, as we said, wide open. Right now, the only therapeutic we have is monoclonal antibody, but as we talked about, that's cumbersome. So if we had an oral option that was more effective or as effective, that is clearly now a key focus. Many of you heard about earlier this week, molnupiravir, which is Merck's drug, went in front of the FDA advisory committee. And I would say it got a lukewarm approval at best. And when you look at the data, you can see why. Now, this drug is named after Thor's hammer. It is a broad antiviral for RNA viruses. In fact, was first looked at for influenza. It is a prodrug, meaning it's well tolerated orally and then converted in cells to the active component, which then affects the RNA polymerase of viral replication. The initial abstract that was reported in early October was looking at about a 50% relative reduction in patients at high risk for hospitalization with early COVID versus placebo. When we looked at the data that was presented at the FDA, that dropped to a relative risk of 30% and an absolute risk of hospitalization or death of only 3% between placebo and control. So you can see why it's a little bit tepid. But nonetheless, 40 pills taken over 5 days. Again, timing would be crucial like monoclonal. So as Dr. Vanderhoff said, it's got to be linked to testing and accessible testing, and then obviously then release of the therapeutic. The other kid on the block, which we have not seen any data on, is Pfizer's Paxlovid. This is linked with another protease inhibitor, ritonavir, which those of us in HIV are well recognized. The preliminary report looked at a relative risk improvement of hospitalization or death or outcome of almost 90%, but we have not seen that data. They will also go up in front of the FDA advisory committee, so we'll learn more. So what I would say on both is these are, I don't think we have a home run yet in terms of here, and certainly it's not right in front of us. And so again, we pivot to control what we can control. And these are the things that Dr. Vanderhoff has continued to emphasize: vaccination, boosting, and again, non-pharmacological interventions for those at risk to prevent acquisition of all respiratory viruses, but including COVID-19.
So Dr. Gordon, on that note, COVID-19 boosters, of course, have been fully authorized for vaccinated adults 18 and older. And so for those who received an mRNA vaccine, we're talking about eligibility 6 months after their second dose, while for the J&J recipients eligible for the booster of their choice, 2 months following the first dose. Could you tell us why are these booster doses important, especially in the context of new variants like Omicron on the horizon?
Another excellent question. And we are learning as we move along. So we have other examples of vaccines. I would say our seasonal influenza, where it's not a one and done. And even some of the ones we're looking at adolescents are series vaccines or vaccines where you need potential boosting. For respiratory viruses, which can be tricky, it's no surprise, I think, and it was anticipated that we were going to need boosting. And in fact, this might turn out to be a situation where annually we'll get an influenza combined with a COVID booster. What may change though, and again, this is what we're all talking about now, is with the mRNA platform, you might be able to target boosters selecting for things that are circulating or more worrisome variants. So it won't surprise me to begin to see, as we anticipate, and already the companies are talking about potentially getting an Omicron booster ready. Right now, the boosters you're receiving for the mRNA are the same that we receive for the primary vaccine, except for the Moderna booster is half the dose. But you can see where this may go. And again, it's going to be the epidemiology and the science that will drive it. But we have now the technology and the platforms, and we have the doses available here in the homeland to, again, get that boost. So your immune system, again, begins to see. You'll get that elevation in antibodies. And the hope is, of course, that will also help not just for Delta, but potentially for other variants that we have not seen yet in terms of protecting against severe disease. And I think that was another important point. We're not looking for sterilizing immunity. If I walk away with a breakthrough with a cold, I'm comfortable with that. It's the hospitalizations and death that are really the key markers here for efficacy.
Yes, thank you so much, Dr. Gordon. Next, I'm joined by Dr. Carrie Warshak, a UC Health physician and professor of OBGYN at the University of Cincinnati College of Medicine. Of course, Dr. Warshak, we know that the CDC, the American College of Obstetrics and Gynecology, and the Society of Fetal Medicine have all recommended COVID-19 vaccines for pregnant women. However, the majority of pregnant women still remain unprotected by vaccines. Dr. Warshak, we know that a woman's immune system changes during the time that she's pregnant, putting her at greater risk for the complications of COVID-19. Could you share with us a little bit about the risks to a pregnant woman who becomes ill with COVID and how those risks compare, for example, to their non-pregnant counterpart?
Sure, thank you. And first of all, let me thank you for inviting me to participate in this briefing today. Yes, you're exactly right. Pregnant women characteristically are predisposed to more complicated courses with many infections, such as the flu. With COVID, we have not found pregnant women necessarily to be more susceptible to becoming infected. However, we have found pregnancy does increase the risk of severe infection. Thankfully, similar to non-pregnant women, about 90% of pregnant women will have uncomplicated courses that either have mild symptomatology or even asymptomatic courses that do not require hospitalizations. However, there are now consistent and alarming reports that the rates of severe COVID are much higher when infection occurs during pregnancy. For example, we have found that pregnant women are 2 to 3 times more likely to require mechanical ventilation and ECMO compared to non-pregnant women that are age matched. That we've also found they're 18 times more likely to require an ICU admission. But of course, pregnant women are at increased risk for medical issues. So a recent study sought to look at this a little bit differently, and Inter-COVID compared pregnant women who become infected with COVID to pregnant women who do not become infected with COVID. They also found much higher rates of ICU admissions, a 5-fold increase. And of most concern, they reported a 22-fold increase in the risk of maternal death in pregnant women who become infected with COVID. Again, compared to pregnant women who do not become infected with COVID. They found higher rates of earlier delivery as well as blood pressure disorders of pregnancy, such as preeclampsia. So although the majority of pregnant women will have mild infection, there is no doubt pregnancy is absolutely a risk factor for severe COVID. I would also add that the management of pregnant women who get very sick with COVID is often very, very complicated, secondary to the needs to balance maternal risk and benefits versus fetal risk and benefits.
Yeah, thank you, Dr. Warshak. With all of that context, I know that an additional concern that most pregnant women have is just about safety and safety of whatever they are putting into their bodies during pregnancy. Can you share a little bit with us about the safety of the vaccines? Are COVID-19 vaccines safe during pregnancy? Does getting a COVID-19 vaccine, for example, increase a woman's risk of a miscarriage?
Yes, absolutely. I hear and discuss these concerns every day face to face with my patients. So I'm very well aware of the multiple and varied concerns that pregnant women have regarding vaccination and pregnancy, and for good reason. Pregnant women are generally very reluctant to start any new medication or have any unnecessary exposures. As physicians and OB-GYNs and maternal fetal medicine physicians, we are very cognizant and respectful of these concerns. However, the bottom line is all indications are that the vaccine is very safe and even more effective at preventing critical COVID than we had even initially predicted in non-pregnant individuals, and thankfully in pregnant individuals as well. One example is the CDC V-Safe app, which has collected 36,000 participants that indicated that they were pregnant at the time of vaccination. Remember, 94% of these participants were healthcare professionals, so they were therefore very knowledgeable and reliable study subjects. Pregnancy outcomes that they have reported showed no indication that there's a higher risk for any of the common causes of concern for women that are pregnant. Notably, the risk of miscarriage was reported at 13%. That is absolutely similar to historical rates that are reported and rates in non-vaccinated women. The rates of birth defects was 3%. Again, that is no different. The rate of preterm delivery was 9%. No different than historical rates or rates in non-vaccinated women. They did have one reported stillbirth. That risk then was reported as a rate of 0.1%. And again, we generally report the risk of stillbirth in any pregnancy is somewhat less than 1% historically. So very much similar to what we would expect to see in that many women. We are expanding data, both observational and based on clinical experience. All of this has not identified any safety concerns for COVID vaccination. I guess I would say to all the pregnant women who may see this, the best way to protect your baby is to protect yourself. We have a safe, proven, reliable weapon against this virus, and that is vaccination.
Thank you, Dr. Warshak. One final question, and that's in regard to boosters. Some individuals may have gotten vaccinated before they got pregnant. Now they're pregnant, wondering about boosters. What would you recommend to them regarding getting a booster?
Yeah, so far the recommendations for vaccination for pregnant women pretty much have mirrored those for non-pregnant women. ACOG does recommend that pregnant women and women within 6 weeks of their delivery receive the booster as recommended by the CDC. This recommendation is based on their vast experience with use of the vaccine in general. And in pregnancy, there's really no reason to believe that the booster would pose any new or additional risk. I would also note that we have done studies and do know that the vaccine produces antibodies, and those antibodies can be found in the fetal circulation and cord blood even 15 days after the first shot. We also know that they pass into breast milk, and I believe that as research evolves, we will confirm that there is likely a neonatal benefit to maternal vaccination and booster vaccination in pregnancy or during breastfeeding.
Thank you very much, very helpful. Well, COVID-19 on an individual basis can really be very unpredictable. One person may have an asymptomatic case while their neighbor who looks just like them could end up hospitalized. A friend may have mild disease, and yet one of their relatives could pass away following a severe illness. If you're unvaccinated, there is simply no way to tell which fate could befall you if you become infected with COVID-19. If you're unvaccinated, you're vulnerable to COVID-19 and potentially to the lingering effects of long COVID. Those who have chosen to be vaccinated, however, we know are well protected from severe illness and death. If you're not yet vaccinated, please go get your shot today. And if you're eligible for a booster, don't delay that. Protect yourself today. And now I think we're ready to take questions, maybe.
Your first question is from Brian Gruden with Fox 8 News.
Yes.
Brian Gruden, are you on? Okay. Next question is from Larry Seward with WCPO.
Good afternoon, doctors. My question is regarding take-home testing. Are you aware of any shortages of take-home test kits in the state of Ohio and any of the rural counties in particular? And what do you think of the president's plan to alleviate costs by having insurance companies issue reimbursements? And is there a need for that in Ohio?
Well, yeah, thank you very much for that question. You know, in terms of availability of testing in the state of Ohio, through the many different ways a person can get tested, we actually have fairly robust availability of tests across the state. Now, at any given time, in any given location, just given the sheer numbers of people who are seeking testing and some of the mechanics of replenishing tests after it is used up, there can be periods of time where a test may not be immediately available. That's why we do recommend that if you're going to, for example, a local health department or a library to seek a test, it's a good idea to call ahead and make sure that they have supply available that day. But as I've shared with the sheer numbers, 3.8 million of our free tests that have been distributed, and then you layer onto that the many tests that are available through retail locations, through pharmacies, through physician offices and health systems. We have a large amount of testing that's available. But rest assured, we continue to look for ways to increase that availability. You know, in terms of any steps that can be undertaken to reduce the barriers to people getting tested, I think from a medical point of view, we don't want there to be barriers that can be avoided. I can't really speak specifically to the policy question of what the president has recommended, but I can tell you here in Ohio, our interest in reducing those barriers is reflected in the fact that we have offered so many tests at no charge at all through our state testing program.
Your next question is from WEWS Cleveland. Okay. Your next question is from Dan DeRoos with WOIO.
Good afternoon, Dr. Vanderhoff.
Good afternoon.
Sir, I'd like you to address, obviously here at WOIO, we're in Cleveland. Can you explain what's going on here in Northeast Ohio? Do we know why our numbers seem to be highest? In the past, you know, we've seen Northwest Ohio because of Michigan. We've seen Southeast Ohio because of Kentucky, but this is really kind of the first time that our numbers have really been higher than the rest of the state.
Yeah, you know, it's very interesting. It's very, very hard to explain how this variant, how this virus is moving around the state and impacting populations. So I don't think we really do have a particularly detailed or good explanation for why one region at any given time But it is clear that the virus is seeking out those who are unvaccinated. And we have unvaccinated populations all across the state. So I think our best recommendation is, get out there and get your vaccine. I'll turn to Dr. Gordon, who practices in that region. Do you have anything to add?
No, I think it's a great question. I mean, I think we have to remember too, we're coming off of a holiday vacation in terms of there was a lot of mobility. And, if you look at Michigan's numbers, actually everywhere in the Midwest is up. But yes, we are feeling it here in Cleveland, to your point. And I just want to underscore what was said by Dr. Vanderhoff. Our troops need to be, we are feeling that wash, and it is affecting care. I think if you look at emergency room wait times, you probably have people that are abandoning care, and so we're seeing that critical point. And then we just have to get back to, as we said, this is primarily being transmitted by the unvaccinated, and that's the burden, and that's the opportunity, and that still remains the challenge.
Bruce, one thing maybe to add also would be, I think there are various levels of wearing face masks around the state. I think if you're going to be in public around people you don't know their vaccination status, you're best off to be wearing a mask. It's going to protect you in addition to being vaccinated to a great degree. And I think this is really the ripples of any little infection that causes another infection, any infection that we can prevent, either through vaccination, face masking, et cetera. Benefits the entire community, the entire state down the road by not having that next patient get infected and they infect 2 more people, et cetera. And I think also it's important to note that, Dr. Gordon and his colleagues up in Northeast Ohio really are supporting an entire region for their hospital beds, as I was describing earlier. So it's been a community effort across the board. Cleveland Clinic, University Hospitals of Cleveland, SUMA, Altman, all of the St. E's over in Youngstown, all working together to try and make sure that patients are cared for as best they can. But Dan, that's a great question.
Okay, your next question is from Alexis Mumberger with WSIX.
Thanks for answering our questions today. So kind of a little bit more on what was just said with this spike in cases that we're seeing. Is it all to do with a holiday lag as far as cases, or really what is that spike contributed to really over the last just 2-3 days?
Yeah, so that's a very, very good question. And I think there is no doubt that we are seeing some impact of the holiday and people coming together. It's likely that we'll continue to see that play out yet for a number of days, because remember, there tends to be a little bit of a lag between exposure and then cases popping up. But it comes on top of already a very large number of cases and a growing number of cases that we've been watching for a period of weeks. And there is no part of the state that is protected or immune from this impact. If you look at near all the counties across the state of Ohio, you're looking at very high rates of new cases being reported. That means there are very, very high rates of transmission. So again, the message is very, very clear. We need to do all the sensible things we can to prevent the spread of this virus, beginning, and most importantly, with getting vaccinated, and if we're eligible, getting our booster shots, because clearly building that immunity within our own bodies is the #1 best way to protect ourselves and reduce the spread of not only Delta, but other variants to come.
Your next question is from Titus Wu with the Columbus Dispatch.
Hi, doctor.
Hi.
My question is, kind of with this, Omicron variant. I know we know this. We're still kind of weighing on the details of, how exactly it'll play out. But suppose that if after further studies we find that it is pretty effective against the vaccine, or
Yes,
or
yes.
it spreads way quicker than we think it is, or whatever they found out about it. I'm just curious, with given how high hospitalizations are, if that turns out true for the Omicron variant, would that very likely push Ohio past its capacity to, handle the surge in hospitalizations?
Well, of course, we watch that kind of information very closely, and as Dr. Thomas shared, and I'll give him a chance to share a little bit more of the detail around this, but we have a very robust system that allows us throughout every week to be carefully looking at exactly what's happening day to day in our hospitals and healthcare systems, because we know that that is the last wall of defense. That's, we have to preserve the ability of people to get care, and that is being challenged now. But we don't know enough about this variant, and it is not yet driving the cases that we're seeing here in Ohio. Again, all we can do is look at the experience that others who have encountered the virus have shared with us. Fortunately, while they have in South Africa reported that it is very contagious, what they did not find is that it was causing a surge in hospitalizations. Now, they were also looking at a population that was impacted that was relatively young. Could that have had something to do with it? They were also looking at a much less well-vaccinated population than we have here. One thing, though, was extremely clear. Again, nearly all the hospitalizations they were seeing were happening among the unvaccinated. So it's just one more indication that as we know Omicron's on the horizon, we ought to do what we can to get ready, and that is getting vaccinated or getting our boosters if they're due. Dr. Thomas, could you share just anything more that you think would be helpful regarding how our hospitals are always looking around the corner and preparing?
Well, I think two things I'd share. One, first, Bruce, based on the last question that you received around the impact of Thanksgiving. In zone 2, our numbers for hospitalizations hit our most recent minimum on November 6th, which was about a week after Halloween. And have actually been slowly rising since then, only to start rising more quickly here the last few days. So I think this is a trend that's been coming for a little while. To your point, it's not related to this new variant yet. Some of it's related to the cold weather and people just being indoors more with each other. So I think our fear, much like when we were sitting here this time last year, is if these trends continue through the month of December into January, we will be at a point where the hospitals of Ohio will not be able to take care of all the patients we need to take care of. And I'll be direct. I think there are some hospitals in the northern part of the state that have already started limiting elective procedures and elective surgeries, things that are not related to a cancer diagnosis, not related to a life-threatening or organ-threatening diagnosis, in order to make sure they have the capacity in their hospitals to take care of the patients that are there. I know at Ohio State, we took 2 patients in the past week from, for those of you who don't know the geography well, Fulton County, which is to the west of Toledo. These were 2 patients who did not have COVID, but were there for other serious medical issues that could not be cared for in the hospital they were at. They had called every hospital in that part of the state, and it had to be at least a 3 to 3.5 hour drive to get those patients to Columbus, but we got them to the right place for the right care at the right time. Those partnerships are terrific, but I'll tell you the capacity in any system, no matter how big you get, even across the whole state, there is a limit to that capacity. And as I mentioned, our staffing issues from earlier in my comments, we just don't have that elasticity. People are frankly feeling burned out. That ability of people to work overtime, work extra shifts, whatever it might be, is just not there like it was a year ago, especially when there's been a solution to a great degree to this problem available for a year. And unfortunately, a lot of the citizens of our state have chosen not to get vaccinated. So I think the comments that have been made earlier, I stand by in terms of the importance of vaccination to really making sure we can weather the storm of this coming surge in hospitalized patients.
Your next question is from Julie Washington with the Plain Dealer.
Yes, Julie.
Your next question is from Paul Teasley with the Hannah Report.
Good afternoon, Dr. Vanderhoff. Thanks for taking our questions.
Yes, absolutely. Paul, you're showing up as muted on my screen.
Very sorry.
That's okay.
The White House, you probably know, announced yesterday that, among other things, the administration will, quote, start paying healthcare providers to advise families on juvenile COVID-19 vaccination. You know, I guess in view of the oath doctors already take, will the state of Ohio participate in this, since this is federal money that flows down to the states? And if so, why?
Well, unfortunately, I'm not familiar with that. I can't really speak to it in much detail, but I can tell you this. Physicians, a big part of what we do, especially in the primary care environment, is to provide education, and that education takes time. So I think any step that we can take to help support physicians with the time they're taking from their clinical practices, and the other healthcare providers who work with them, is a good and helpful thing, because their time is important, and it is an expenditure of the practice's resources to have them doing that. So, generally speaking, I think that providing financial reimbursement for the medical teaching that physicians do in the course of their patient care can be very helpful.
Your next question is from Pete Grieve with Spectrum News.
Good afternoon. Compared with earlier months of the pandemic, Ohio labs are, tracking more of the virus samples to determine which variant it is with sequencing. Can you talk about how that will guide the Ohio Department of Health's response as we await the possible arrival of the new variant?
Yeah, absolutely. So, as we shared before, we really have put a lot of emphasis on the ability of the state of Ohio to do careful and ongoing surveillance for the various variants of this virus, and to understand what's here and how it is impacting the dynamics of the COVID-19 pandemic. For example, that data, that information has really allowed us to be very, very confident that what we're seeing right now, today in the state, is being driven by the Delta variant and various slight variations of that family of viruses. We also are able to say from that data that Omicron is not driving those dynamics in any substantial way now. Could it be here and we've not yet detected it? Of course, that's possible. But what we do know is if it were present in any substantial manner, we would be detecting it. And the reason we know that is because we've just gotten to be so good about gathering up samples that are able to be scrutinized by many laboratories across our state, who are then able to do the genomic sequencing. And there's another opportunity that we have, and that is that when we simply do the PCR test, there is a phenomenon known as an S dropout, or a failure to detect the S genome, which relates to the spike protein genome in that PCR test. Now, that does not necessarily tell us with certainty that it is Omicron. There are actually some other variants that can do that as well, but it's a clue. And it would be an indication that we're seeing something different. And to date, we've not seen a change in that pattern of, quote, S dropout on the PCR tests. But regardless, the next step is we take those PCRs as I described. It has to be a PCR test with sufficient volume and a significant, essentially, concentration of the virus to enable us to go on and do the genomic sequencing that feeds then the information we post on our website regarding variant activity. So I hope that answered your question.
Bruce, one thing to add, I know you've mentioned this in previous press conferences I've seen, it's just important to note from the patient's perspective, since it takes upwards of a week to have that sequencing information back. The steps that you need to take as a patient if you are diagnosed with COVID have nothing to do with what variant you have. So it's not like if you have a different variant, now I don't need to isolate myself. I don't need to wear a mask. I can go to work. No matter what variant you have as a patient, you need to take the same steps to isolate yourself, to keep your friends, family, and loved ones, coworkers safe. Really, the type of variant it is really more something Dr. Vanderhoff and his epidemiology colleagues are interested in, as opposed to maybe the impact it has on you as a patient and your health.
Our next question is from Sarah Schuckman with WKYC.
Yes.
Good afternoon. Yes. So I have a question about breakthrough cases. I don't know if the state or any of the hospital systems represented today could talk about through your own testing, how many cases or what percentage of cases you're seeing are breakthrough cases, and also perhaps how booster shots for those eligible can help potentially fight these breakthrough cases.
Yeah, that's a great question. And for anyone who's interested, we actually post on our website the information or data regarding breakthrough cases right here in Ohio. And fortunately, to date, the number of both breakthrough hospitalizations and breakthrough deaths remains very, very low in the state. The exact numbers, again, are posted there. But it's important to understand what we consider to be a breakthrough. A breakthrough, from a medical point of view, really is not the person who is vaccinated and develops some mild to moderate illness. Remember, these vaccines are designed primarily to protect you against severe disease, hospitalization, and death. We do anticipate that, especially over time, as time builds from the last time that you got your vaccine, that there will be some degree to which vaccinated people can develop some degree of symptoms and illness. But the vaccines have done an incredibly good job of protecting people from severe outcomes. Now, getting your booster shot bumps that immunity right back up and actually creates a window of time where you're even unlikely to develop mild symptomatic disease. But again, that tends to be a relatively short window. So you can turn there for information, our website, on the exact numbers. Couple of my colleagues, I think, are probably able to speak a little bit more to the issue. And I think I'll turn to them and just see what else that they would like to add.
Yeah, Dr. Vanderhoff, if I can just weigh in, I think the thing to understand, as you mentioned, is that the PCR test can be positive for 90 days. And so the definitions are important in the time intervals. So we see a lot of patients who are coming in for screening pre-surgical that still might have, because we're screening everybody, still might have a positive PCR. When you look at the cycle thresholds, are generally extremely high, which is not clinical infection and not a breakthrough. You know, true breakthrough would require, to document not just time, but sequencing. And to date, that has not been a focus even at CDC. So your question's a good one. And breakthrough can also be defined by breakthrough after natural infection, which is another interesting area of research, because you do get immunity after natural infection. We just don't know how durable that is. And that's another reason why we still recommend, even if you've had COVID and not been vaccinated, yes, get the initiation, get the vaccine, whether you want to consider that to be a booster or not. That's important for protection. So there are some nuances there. The other population that we see, and we see at OSU as well, is the immunosuppressed population. So these are the patients that sometimes never clear. And again, the speculation with the little Omicron might be is that this was a patient that just continued, couldn't clear, and that the mutations were just acquired within the same patient as opposed to a linear progression in the community. And all of us have transplant patients or have seen patients on severe immunosuppression who have not cleared. Their test remains positive for a long time. So that's another area of surveillance now. It's been going on in terms of looking for variants.
Okay, that was our last question that we have time for today. Dr. Vanderhoff, would you like to make some concluding remarks?
Sure. Thank you very much. Well, first, I want to thank my guests today for the information and expertise that they were able to share. It's very, very valuable. So thank all of you. And also thank you to those of you from the press. I think the message today is very clear. It's vaccination. We really need people to take advantage of the opportunity to get their vaccine or get their booster, particularly as we look at the potential future threat of the Omicron variant. So thank you all very much.